Tired of getting tangled up trying to figure out surgical wound debridement codes? Well, you are in exactly the right place. In this explainer, we are going to break down CPT codes 11042 through 11047 using a super simple framework that's going to help you code with confidence every single time. Okay, let's get into it.
And believe it or not, you can pretty much master this entire set of codes just by asking 2 simple questions. Seriously, that's it. So you can say goodbye to all that confusion and second guessing. By the time we're done here, you'll see exactly how these 2 questions unlock accurate coding that, actually holds up and ensures you get paid correctly. So here's what we're going to cover. We'll start with the basics, then we'll dive right into our 2 key questions, depth and surface area. After that, we'll see how this whole thing applies to those trickier situations with multiple wounds. We'll quickly go over what these codes don't apply to, and then we'll wrap it all up with the golden rules you're not going to want to forget.
All right, first things first, let's build a really solid foundation with the basics of debridement coding.
So what are we even talking about with surgical debridement? Well, officially, it's the removal of devitalized, contaminated, or infected tissue to promote healing. In plain English, it's the skilled process of cleaning out all the dead, infected, or gunked up tissue from a wound. The whole point is to give the healthy tissue a clean slate to grow, basically kick-starting the healing process. This idea is the bedrock for everything else we're about to discuss.
And here it is. This is where it all starts. Every single coding decision you make for these codes, it all comes down to just 2 things, depth and surface area. How deep did the surgeon go, and how big was the area they cleared out? So let's tackle that first question right now. Okay, our first big question is all about depth. And when we talk about depth, we are always, and I mean always, focused on the deepest level of tissue that was actually removed during the procedure. This slide lays it out perfectly. The best way to think about it is like steps on a ladder, going down. The top rung, the most shallow debridement, is the subcutaneous tissue. That's code 11042. Go 1 step deeper, down to muscle or fascia, and you're using 11043. And the deepest level, the bottom of this ladder, is bone, which gets you code 11044. It's just a simple progression, deeper and deeper. So here's the crucial rule to remember. For any single wound, you only report 1 primary code, and that code has to represent the deepest layer the surgeon reached. So even if a doctor debrides some subcutaneous tissue on the way down to the muscle, you don't code both. You only code for the muscle debridement, the final destination. This is a really common mistake, and it's a quick way to get your claims denied.
Okay, we've totally nailed down depth, so now it's time for our second question. What's the surface area? This is where we start thinking about the size of the wound, and it's where our add-on codes come into play.
I want you to burn this number into your brain, 20 square centimeters. Why? Because those primary codes we just talked about, 11042, 11043, and 11044, they only cover the debridement of the first 20 square centimeters. So what do you do when the wound is bigger than that?
This table shows you exactly how it works. It's actually a perfect system. Each of those primary depth codes has a specific partner, an add-on code, for any extra surface area. So for subcutaneous tissue, 11042 covers that first 20 square centimeters. For each additional 20 square centimeters, or any part of it, you report its buddy code, 11045. And the same logic just follows right down the line. 11043 for muscle pairs with 11046, and 11044 for bone pairs with 11047. Simple as that.
Okay, so we've got single wounds down pat. Now let's tackle the stuff that can get really confusing, cases with multiple wounds. But don't worry, we're going to apply the exact same 2-question framework. Now this is probably the most important rule for coding multiple wounds, so listen up. If you have a few wounds and they're all debrided to the same depth, you just add up their surface areas and code that total like it's one big wound. But, and this is so important, you never combine the surface areas of wounds from different depths. Getting this wrong is a surefire way to get a denial or even trigger an audit.
Let's make this crystal clear with an example. Say a surgeon debrides 2 different wounds, both of them all the way down to the bone. One on the heel is 4 square centimeters, and one on the ischium is 10. Since they're at the same depth, bone, we just add them up. 4 plus 10 is 14 square centimeters. That total is less than our 20 square centimeter threshold, so we just report 1 code, 11044. Easy.
Now let's see how an add-on code works in this situation. Here we've got 2 wounds, both debrided down to the subcutaneous tissue. One is 16 square centimeters, the other is 10. Again, same depth, so we add them up. That gives us a total of 26 square centimeters. This time, our total is over that 20 square centimeter limit. So we report 11042 for the first 20, and then we grab its partner add-on code 11045 one time to cover that leftover 6 square centimeters. Makes sense, right?
So what if the wounds are at different depths? Let's say one goes to muscle and another goes to bone, all on the same day. You have to report each depth separately. But to make sure the payer understands these were two totally separate procedures, you have to add modifier 59 to the second code. Think of it like a little flag you're raising that says, hey, this was a distinct procedural service. Don't bundle these together. It's what prevents an incorrect denial.
Knowing what to do is half the battle, but knowing what not to do is just as important for clean coding. So let's do a quick run-through of the exclusions for this code set.
Yeah, it's really important to remember that these codes, 11042 to 11047, are specifically for things like ulcers, infections, and injuries. They absolutely do not apply to procedures like dermabrasion, nail debridement, burns, or the excision of pressure ulcers. All of those have their own special CPT code ranges, so just make sure you're in the right section of the book for the procedure that was actually done.
Wow, we've covered a lot. So let's boil it all down to the golden rules, the key things you need to walk away with today.
If you remember only one thing about a single wound, make it this. Your code is always, always determined by the deepest point of debridement. Period. Don't overthink it. Find the deepest documented layer, and that tells you your primary code.
And for multiple wounds, this is your mantra. You got to keep your math separate. Add up all the subcutaneous areas together, all the muscle areas together, and all the bone areas together. You sum by depth, you never sum across depths. Sticking to that one principle will keep your coding clean, accurate, and totally audit-proof. So there you have it. You've got the framework. You know the two questions you need to ask. What's the depth and what's the surface area? But, this brings up one final, really critical question. You can pick the perfect code every single time, but is the clinical documentation from the provider strong enough to actually back up your choice? That right there, that's the vital bridge between great coding and actually getting paid. Just something to think about.